This PowerPoint is going to encompass all of the modules that you have assigned in the Engage Pharmacology book. In medication safety, we have several processes that we follow in order to make sure that we are reducing medication errors. Medication error is probably the biggest error in healthcare that we see. We've advanced in our technology so that we have electronic medical records, and so we're able to look electronically, and it's supposed to ask us some questions. When we scan the medication, we scan the barcode, we scan the patient, their barcode as well. And if we scan a medication that is not supposed to be given, the computer will say, wait a minute, now are you supposed to give this medication? So we're going to talk about the rights of administration first. There's 10 rights of medication administration. Now, way back we started with 5 rights and we've gradually built up to 10, but the reason we have so many is because of medication errors. And so we want to make sure that with each error that we see, or if we start to see a group of errors, that we are doing the processes we're supposed to do correctly. So, right client, right, we know that we have to use 2 patient identifiers. So you'll ask them, what's your name, what's your date of birth? In the hospital, we'll usually scan their armband and it'll pop their name up on our computer. We want to make sure we're getting the right medication, make sure that we have the right medication, and we have completely looked that over. You should look a total of 3 times over your medications. Make sure we're giving it in the right form. Is it supposed to be a pill? Is it supposed to be an injection? Right dose. We want to check the dose that we're getting ready to hand to our client against what the order says. The right route, again, that goes back to what I mentioned earlier. Is this something that's supposed to be given subcutaneously? Is it an IM? Is it IV? The right time, make sure that that's given at the correct time. Now, in healthcare, we usually have about an hour before and an hour after medication is due in order to give it, but that would be more for routine meds. Now, if you're giving someone an as-needed, maybe pain tablet, we want to stick very closely to that scheduled 4 hours or whatever the order says. Right assessment, we want to make sure that our client is not allergic to the medication, that it's something appropriate for them. So for example, if we have someone who's in the hospital because they had surgery to remove their appendix, and we go in and try to give them insulin, well, that is not recommended for that client unless they have diabetes. We also want to look for any interactions. We have a lot of drugs that interact with each other. We have foods that interact with some medications. Probably the most common you'll see is going to be grapefruit juice. It interacts with so many different things. The right documentation. It's very important that we document when we give a medication. We need to document immediately when we give that medication. Never document before, because we might document that we gave it and that patient or that client refuses it, and so we've put out some dishonest documentation there. Right to refuse. They have the right to refuse their medication. Now, we're not just going to say, okay, here we go. You can refuse it, but we want to educate them on why they need to take it. So for example, a lot of clients post-surgery will be put on Lovenox shots. Well, they don't like those because it stings. It's given in their belly. It's a subcutaneous shot, and they don't like the way it feels, and so they just opt not to get that. So it's important that we educate them the reason we're giving them that shot, and say, hey, we don't want you to get blood clots while you're here healing. This could save your life. Educate them, then they still have that right to refuse. The right education, that's kind of what I just talked about as far as what's the benefits of this medication. Are there any adverse side effects that we need to be looking for? And the right evaluation. So we always want to go back and check our clients, particularly if we have a pain medication, we want to go back and check them and see what their response is to that medication. So for example, if I'm giving someone a medication to lower their blood pressure, when I go back and recheck their blood pressure an hour or so later, I should see a decrease in it. All right, one of the things that we do is medication reconciliation. When we transfer them from one location to another, we want to do a medication reconciliation. So you may see this done in a clinic. Whenever you go to visit the doctor, they'll say, have you seen, are you still taking these medications? If we're going from, say, the hospital to long-term care or vice versa, we want to do medication reconciliation. This helps to ensure that continuity of care. So it helps to prevent any errors in drug interactions. And again, we want to do this from the first time we see them and then all the way throughout as we're taking care of them anytime we're changing things. It's important that we get all medications, so we have to remind them sometimes, are you taking any over-the-counter medications? Do you take any herbal supplements? Because a lot of times they don't consider those medication, and there are some of those supplements that can interact with their other medications. All right, so this is the steps of medication reconciliation. We want to get a list of their medications that they're taking. Again, prescription meds, over-the-counter meds, herbal, dietary supplements, all of those. We're going to compare that list to what we have in our medical record, validate each medication, make sure it's the right medication, right dose, right frequency, and ask them, are you taking these medications as prescribed? So again, going back to my blood pressure client, let's say I have a patient who has been put on blood pressure medicine and they're there for a follow-up and their blood pressure is still high. It's going to be pretty important that I ask them, are you taking this blood pressure medication? Because they may not. They may say, well, it gave me a headache, so I just quit taking it. And we might increase that dosage and it's not going to do any good because they're not taking it anyways. We also want to make sure that we are comparing the hospital list, the physician office list, with their home medications as well. And anytime that we have a new medication, we want to look at their list of medications and see, are there any interactions that can occur here? And then, of course, the last thing we want to do is communicate any changes. We need to tell our client, we need to tell all members of the healthcare team that are involved in their care. Medication administration errors, they can occur at any part of the process. Anytime we see a discrepancy on something, any questions that we may even have, we want to ask. It's okay for us to ask the pharmacist. It's okay to talk to the prescribing healthcare provider and ask them, what did you mean by this? I just want to clarify. There's nothing wrong with doing that. If we don't, we can have something called a sentinel event. A sentinel event is a bad event. Okay, this is when these med errors happen that cause the patient harm. Okay, we also want to make sure that we're working together, that we're using our evidence-based practice, we're communicating, we're being sensitive to the client's culture. We want to make sure that if we were to have an administration error, that we are reporting that appropriately. So usually you have to fill out some type of incident report. You have to call the healthcare provider. You may have to call the patient's family. So anytime we see an error, it is a legal and ethical responsibility for us to report that error. So sometimes maybe we don't know about the medication. Maybe we don't realize that we're giving two different blood pressure medications. Maybe someone has not communicated to us that there is a medication change. We might be so busy or short-staffed that we don't have time to check through the client's records. A big thing, especially that we see in long-term care, is distractions or interruptions. So we might be going around administering our medicine and someone says, hey, wait, I need to ask you a question about this. You get distracted and you forget what you did. So that's probably the big thing that we worry about. Also, standard procedures. That's why we have these policies and procedures, so that we know what the correct steps are. Listen, people will make mistakes. You will make med mistakes. I have made med mistakes. I probably will make another med mistake sometime in my life. We just have to be responsible and own up to it and admit it and then correct it. It's something we all do. Some different error classifications. Rule-based, that's when we're not adhering to the standards of practice. Knowledge-based, this is when I don't know about that medication. I don't know a client history. Maybe they've had an insensitivity to that medication before, or maybe I don't know how to give the medication. Activity-based, these are the things like distractions. If we check our email or stop to text in the middle of a med pass, things like that, not answering our calls, maybe we get distracted by an alarm. All of those are activity-based errors. So as the nurse, you want to monitor for the therapeutic effect, and you want to also monitor for adverse effects or even side effects. So it's our responsibility to know what medication we're giving and what we expect it to do. So if I'm giving someone a diuretic, I should see their urine output increase. So I have to know what my medication is for so I can monitor if it's working like it should, okay? The other thing is monitor for adverse effects. So most of us are going to have some type of side effects to some medications. Side effects are okay. Side effects are, maybe I get sleepy after I take a medication. That's a side effect. It's not going to harm me if I get sleepy, but we know that most people, when they take this medication, they get sleepy. Now, what would be an adverse effect is maybe if it causes me to have a seizure or if it drops my blood sugar. So these are the bad things that I'm looking for. If I start having an allergic reaction, and a lot of times it's not the very first dose of that medication that causes an allergic reaction, it's that second dose or subsequent doses that we'll see the allergic reaction. Pharmacodynamics, this is how that drug works. So when we talk about something being at its peak level, that is when it's at the highest level of concentration, okay? Not always where we want it to be, but it's at the highest level of concentration. We might get something called a peak and trough, especially if you're looking at something like vancomycin. A peak will draw so many hours after we administer that medication. That's when the medication should be at its highest, and trough is when it's at its lowest concentration. Allergic reaction or hypersensitive reaction. This is when our body sees, hey, I've got something here, and it produces antibodies to that substance that it sees. This is all a histamine response. There's difference between hypersensitivity or allergic reaction. Allergic reaction are going to be things like they're going to have itching. They might break out in hives. It might cause them to have their throat swell up. Versus a hypersensitivity, some people just have a hypersensitivity and they call it an allergic reaction when it's really not. So a hypersensitivity would be something like, oh, well, it makes me sick at my stomach when I take it, or it makes me have diarrhea. Two things that we worry about is, number one, anaphylaxis. This is life-threatening. It's going to cause our heart to go up, our blood pressure to drop, difficulty breathing because our airways are swelling up. Another thing, and we don't hear of this a lot, but you will see it when we're going through our drug card. You'll see this as one of the side effects is Stevens-Johnson syndrome. This can occur after up to 2 weeks after we give a certain drug. So they have like a start having respiratory problems, might get fevers, and then these defining thing is they have this really fine rash, and then it breaks out into blisters. Pharmacokinetics is the study of absorption, metabolism, distribution, excretion of the drugs in the human body. Again, it depends when we're talking about distributing that medication out. It depends on what state I'm taking it in. A liquid medication is going to distribute a lot faster than a tablet would. Most medications we give via oral route. That's a slower rate of absorption. If we give something via IV, that's fast. We're putting it immediately into their blood. Distribution is where I'm taking it to the body. So I'm getting it out to the place that it needs to go. So if I have a headache and I take a Tylenol, distribution would be that drug Tylenol going to the pain receptors around my brain and sitting there where the pain is. So metabolism is how we use that drug and excrete it. Most medications are going to be metabolized by our liver. So think about this. If my liver is sick, I cannot metabolize drugs, and I'm going to have a drug buildup in my body. The second area of excretion and metabolism is going to be our kidneys. So think about those two things. Most of them are liver. Secondary would be kidneys. Excretion is how I'm getting rid of that. Kidneys are the primary organ that gets rid of those medications. Now, we can sweat some of them out. We have other different ways to breathe some of them out, but for the most part, kidneys are going to be the organ that's responsible for excreting those drugs. As I mentioned earlier, if we can't metabolize the drugs, if we can't excrete the drug, that's going to build up in our body and we're going to develop a toxicity. Teratogenesis is basically just, it's going to cause fetal or birth defects. So no teratogenesis, fetal or birth defects. When we look at a physician's order or any type of medication order, these are the things that it should have on there at a minimum. We have to have that person's name. We have to know the date and time that it was written, the drug name. Sometimes they use it in generic. Sometimes we use the trade name. However, for purposes of NCLEX, it's always going to be the generic name. We need to know the dosage amount. How are we going to administer it? Is it going to be PO? Is it going to be IM? The route, is it oral? Is it going to go PO through our mouth, or is it going to be rectally? How often? Why we're even given this medication? And then the healthcare provider has to sign off on that they wrote the order. We do have some high alert medications. These are medications that can cause harm to a client when we give them in error. So some of the most common ones, insulin, narcotics, and heparin. Those are very high alert medications. So with insulin, with heparin, usually it's going to have us get another nurse and have them verify the amount that we are giving. So our role, we talked about some of the adverse drug reactions that we're looking for. Again, it can be something like they have diarrhea all the way to they go into anaphylactic shock. We have to provide education to our clients as well. It's important for them to know, why are you even taking this medication? And we may tell them the generic and the brand name of that medication. We want to make sure that we tell them how they're supposed to take it, what time they're supposed to take it. Look for these adverse effects. If there's some type of precaution that they need to take during that therapy, so maybe it says to limit sunlight or limit sun exposure, we want to make sure that we tell them about that. Depending on the age group, is going to depend on how you're going to approach this. So we may, as you see the picture there, the nurse is showing the little girl on a doll how to administer this medication to that girl. Sometimes we might need an interpreter for someone who does not speak the same language as we do. We can also recommend a reputable source for them to go to. Be very careful about sources on the internet that you send your clients to. In hospitals, the nice thing is we have these nice medical indexes that have all types of drug cards in there, and we can print them out a sheet and they can take it and read it later. However, remember that not everybody knows how to read and not everybody is going to read it. So we want to make sure that we have addressed those verbally with them and even have them tell you back what you talked about. Say, so how many times a day are you supposed to take this medication? And let them respond to that. Some things that are going to influence medication adherence, their culture, beliefs, traditions. You may have some clients that will look you in the face and say, yes, 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 I'll take this, I'll take it, I'll take it, and then they get home and they don't take it. Maybe they don't believe that it's going to help them. Maybe they have some type of spiritual or cultural beliefs that they're not going to use those pharmaceuticals. And they might have a tradition in their family where they only use herbs to treat themselves. So we have to be aware of those types of things as well. And again, it goes back to asking them, have you been taking this medication? And if they say no, say, can you tell me why you're not taking this medication? Another thing could be the social determinants. Do they have the ability to pay for these medications? We know that medications are very expensive, and some of them we just can't afford. The patient has to worry about, am I going to eat or am I going to take my medications? Historical trauma. In years past, we know that some cultures, some ethnic groups have had adverse events placed on them where they've been given medications that were detrimental to them. And so if somebody has that type of trauma that they're dealing with, we want to make sure that we provide education to them. All right, so let's look at the routes of administration. First one is oral. This is the most common one we use. Tablets, capsules, soft gels, liquids. They are classified as enteral medications. And again, the rate of absorption is going to differ from client to client. So if you have someone who has a larger body mass, it might take a little bit longer than someone who's very skinny. If you have a full belly, when you take that medication, it might absorb slower than if we have an empty belly. Now, this does require that that person be able to swallow. So if we have someone who cannot swallow, oral is not a good route for them to go. Sublingual and buccal medications, these are administered, sublingual is under the tongue, sub meaning under, lingual meaning the tongue. Buccal medications are in that cheek area, in that mucosa there. They're considered enteral medications, but they're not absorbed through the oral mucosa, they're just absorbed through those mucous membranes. These are going to have a fast rate of absorption. Another type of enteral medication is rectal. We can give medications via the rectum. It's absorbed in through that rectal mucosa. Again, they might absorb those a little bit faster than they would oral. Intravenous medicines, these are parenteral medications. We put this directly into their bloodstream. So it doesn't have to go and be absorbed and metabolized. It is immediately there. So we should see pretty much immediate response. So for example, if I'm giving you a pain medication through your IV, within a minute or so, you should be feeling the effects of that. Intramuscular is another form of parenteral medication. We can give it in the muscle, the deltoid, which is on your arm, the vastus lateralis, which is on your thigh, on the front part of your thigh, or the ventrogluteal muscles. We can give those. Now, it's good because it can get through there pretty fast into the muscle. It doesn't have to go through the stomach and be dissolved and absorbed and things like that. However, there are some risks with it. Number one, for some people, it's very painful, especially if we're looking at some type of antibiotic shot that is painful. The other thing is we could cause a little hematoma there, or we could hit a nerve and cause some injury. The next type of administration we're going to look at is the subcutaneous, and these are just put into those fat layers, so just beneath our dermis is where we're going to put them. So this is where we might put it into the belly, we might put it behind the upper arm, the outer aspects of the thighs. Again, a lot quicker to be absorbed than the oral medication. The disadvantage, again, some people say it's painful. The other thing is sometimes we have to rotate our injection sites so that we don't get a medication buildup and we don't get a lot of hardening of that area. Intradermal, this is things like your TB test. So this is where we give it superficially into the dermis. Absorption is very, very slow with this. And again, the most common place that we're going to see these administered is going to be in the inner forearm. Inhalation is the next one we're going to look at. This is delivered directly into the client's respiratory tract. So it is fast because it goes directly to the site. Otic medications or ear medications, we're going to administer them directly into the ear. We do want to watch for ototoxic medications, meaning it's harmful to the ears. If we have, say, a client that their tympanic membrane is ruptured, we wouldn't want to put a medication in there. Ophthalmic medication, these are medications for our eyes. We administer them into the subconjunctiva of the eye. So drops, ointments, we'll do those. Usually we'll have them pull down that eyelid and we can put it kind of in the inner canthus of that eye. The next one is the transdermal. These are topical medications. Again, it goes directly and is absorbed into that fat, so it doesn't have to go through the stomach and go through all the GI system. So things like you might see a Duragesic patch, which is a fentanyl patch, and it just sends out medication through a series of, say, 3 days. You might see a nitroglycerin patch. You might see a Nicoderm or nicotine patch. Nasal is the next type that we're going to look at. Nasal, it's going to go directly into the nasal cavity. Again, it has fast absorption because we have some mucosa there in our nose. So you might see a nasal spray, a nasal drop. And then the last one is vaginal medications, where we put those medications directly into the vagina. Again, it doesn't have to go through the stomach and metabolize. We put it right there where it needs to be. We do have some medications that we call scheduled medications. The DEA has 5 different schedules, 1 through 5, and you will see these. So examples, Schedule 1, these are ones that don't have a medicinal purpose. They have a high misuse potential. So things like heroin falls into this category. Even cannabis falls into this category. Schedule 2 have high potential for misuse, but they do have a medical purpose when used as prescribed. So this would be our drug fentanyl, not what we get on the streets, but regular drug fentanyl. Some of our stimulants that we give for ADHD and such are considered Schedule 2. Schedule 3 are going to be a lot moderate to low potential for misuse and dependency. This might be things like some of your steroids. Ketamine falls into this category, testosterone. Schedule 4, they have a medical use and they have less potential for misuse than Schedule 3 does, but they still have potential for dependency and misuse. So things like our alprazolam, tramadol, those would all fall in there. Schedule 5 drugs have less potential for misuse than Schedule 4 drugs do. So think about the cough medicine. We give the cough medicine with hydrocodone in it. That's a Schedule 5 drug. So the DEA is very strict about who can dispense these medications. So the healthcare provider needs to have a DEA number that they're registered with before they can prescribe some of these drugs. So when I'm looking at Schedule 2 drugs, they have to have either a written prescription or it's sent through an approved software to the pharmacy. We're not going to call in these medications. The nurse cannot call this into the pharmacy unless it's an emergency. They do not allow you to get refills on Schedule 2 drugs. You have to get a new prescription issued to you every time. Schedule 2, 3, and 4 drugs, you can call in a prescription for those. You can do up to 5 times to refill it over 6 months from the original issue date. Looking at some of our ethical principles. Autonomy, this is the right for us to choose for ourselves. Again, this goes back to that I have a right to refuse any medication. But again, as the nurse, you have to make sure that they have all the education that they need. If it's something that you would not choose and they're choosing to do, it doesn't matter. It is their decision to make. Beneficence is promoting the best outcome for that client and protecting them from mistreatment. So maybe we have a couple of different medications that we can offer someone for pain management. We want to look at the one that's going to give them the greatest benefit with fewer side effects or fewer adverse effects. Beneficence also refers to timely administration of our medications. We don't want them to wait and wait and wait for that medication. We want to deliver it to them when it is time. So again, educate that client about medication use. Advocate. If you see a patient that's having a lot of pain and what the provider has prescribed is not working, advocate for them. Talk to that provider and say, is there something else we can give? This patient is still experiencing a lot of pain. Non-malfeasance, this refers to doing the best interest of the client and avoiding harm. So no harm here for them. Think about probably the most common thing that we see is end-of-life care, withdrawal of care. Again, look back to that medication scenario. If they have 2 different medications for the same thing, which one is going to do more good for them with limit of side effects or harm to that client? Your role as the nurse, sometimes it's hard to uphold these things because maybe you don't agree with it. So we have to think about, again, what benefits, does the benefits of giving this medication outweigh what our risks are? Justice refers to treating that client fairly, appropriately, and equitably. So think about if they can't pay for a long-term medication, what can we do for that? Maybe we can look if there's a generic available. Is there a less expensive medication? A lot of pharmaceutical companies have programs where like they can give you 6 months of medication at a reduced cost. As a nurse, it's important that we know about those things and we help our clients be able to make the best decision for themselves. Very simply, I want to talk about the structures of the nervous system. We have the central nervous system, the CNS, and we have the peripheral nervous system, which is PNS. Central nervous system is easy. It's our brain, it's our spinal cord. Peripheral is everything on the periphery from that. So everything going outwards. That's our hands, our feet, our arms, legs, etc. Know that we have neurotransmitters that are going to send out the neurons that it needs to. It's an excitatory neurotransmitter, sends it out. And then we also have receptors, and a receptor is going to be where it will grab hold of that signal. So For example, think about like little suction cups at the end of your cells maybe, and you have a medication that you take and it attaches to that receptor and it holds on to it. An example of what I'm talking about with the neurotransmitters would be something like our fight or flight response. So think about if someone comes up behind you and scares you, you don't have to stop and think, oh, I'm scared, my heart needs to beat up. Your body automatically sends out those neurotransmitter neurons, and it says, hey, we've got a problem here, we're in danger. And so it's going to cause your breathing to go up, it's going to cause your heart rate to go up, it's going to put your body on alert. Okay, that's because those neurotransmitters were sent out. As a result of them being sent out, we had some physiological changes that occurred. Our heart rate went up, our respiratory rate went up, things like that. We're breathing a little bit faster. Autonomic reflexes, we're talking about baroreceptors. These are going to sense when we have a change in our blood pressure. Okay, so it says, hey, we've got a change in our blood pressure. We've got to react to this. Okay, we have chemoreceptors. These sense changes in our pH, in our oxygen, carbon dioxide, glucose hemostasis. This is from when we eat a meal. It's going to trigger our central nervous system and we are going to awaken some nerves, and it's going to tell our pancreas, hey, we need to send out some more insulin here, or maybe it tells the liver we need to get some glycogen synthesis going on here. Temperature regulation. This is a result of negative feedback. Our body senses those changes by our thermoreceptors in our skin, spinal cord, visceral organs, brain, and it sends out signals to our hypothalamus that, hey, we've got a problem and you need to respond. Talking of those drugs, again, I said we have receptors on our cells, and so those are going to hold on to those medications that we need. So the types of medications that we have are agonist, antagonist, and partial agonists. So agonists are going to increase the effectiveness of that medication. It's going to help it along. Antagonist is going to inhibit that cellular activity. So it's going to stop something else from happening. And you'll see when we get into these medications later on in the course, you're going to see how those react. Partial agonist, it has both agonist and antagonist. So it can bind to those receptors, but it's a little bit weaker. Receptors don't really like these medications, so we might see less therapeutic and less side effects with these.